Good afternoon, everybody. Welcome to Cochin and welcome to this IC on aqueous drainage implant surgery, optimizing outcomes and managing post-operative complications. I am Dr. George PUTHURAN, your chief instructor for this course. And we will start with Dr. Neetu Mohan, who heads the department at Aravind Eye Hospital, Chennai. And for her talk on surgical pearls in aqueous drainage implant surgery, including patch-free tube implantation.
My talk for the day is surgical pearls in aqueous drainage implant surgery, including patch-free tube implantation. So over the next 12 minutes, we'll be going through 12 basic steps in tube surgery, which I feel helps the beginner surgeon. So to start with, it goes without saying that the preoperative planning is a single most important part of the surgery, and assessing the cause of glaucoma, anatomy of the eye and the orbit, age and ethnicity of the patient, previous ocular surgeries, especially previous retinal surgery, the position of a buccal or a sponge, previous trabeculectomies, PKP, DSEC need to be evaluated thoroughly. Also, we need to decide upon the type of implant, whether you're going to use a patch graft, the quadrant of placement, the placement in anterior chamber, sulcus or vitreous cavity, and decision on the use of venting slits, ripcord sutures, and tube ligation has to be done during the preoperative planning. Pre-ligation of the RD helps save time on the table and allows easy visualization of complete ligation. It also allows fixation of the tube at a later point in the surgery, that is after the anterior chamber entry. Intraluminal occlusion of the RD with a 4-row supramid suture reduces the rate of post-op hypotony and related complications at the time of tube opening, that is around 6 to 8 weeks. This is especially useful in eyes which are predisposed to hypotony, like angle closure glaucoma, nanophthalmos, and vitrectomized eyes. Priming of the Hemeth glaucoma valve. As we know, the Hemeth glaucoma valve system consists of two thin silicone elastomer membranes, which is housed inside a casing. So this area is a no-touch zone during tube implantation. This area should not be damaged with the forceps or by rough handling. And priming of the tube should be by gentle injection of BSS rather than a forceful jet using a 27 gauge cannula. A gentle, steady stream of fluid is ideal for priming. It's useful to mark the limbus before taking the traction suture. This allows good conjunctival closure at the end of surgery when you have moved the globe around a lot, and also helps in identification of the recti during placement of the RD. A good exposure, traction, and blood-free field makes surgery much more hassle-free, rather than struggling blindly in a field with lot of bleeding. It is always better to have a better exposure. Put another relaxing incision to the conjunctiva and place the plate under direct visualization so that the damage to the muscles are minimized and there is less undue damage to the tissue around. So as you can see, a small relaxing incision gives so much more of visibility, and the plate can be placed under direct visualization with less damage to the surrounding tissue. Confirming the plate position is mandatory every time. There should be a restricted anterior movement of the plate as seen here, and the posterior movement should be very free into the orbit. And it's also a good idea to mark 9 mm away from the limbus at this point so that any untoward movement of the plate anterior later on in the surgery will be easily noticed. And once this is done, the traction can be removed. Now after this, we can decide on the site of entry. Looking at the area of scleral thinning and scarring, you can decide which would be the ideal site for tube placement. An area of peripheral anterior synecdoche or corneal opacity can be avoided. And if a tube is placed in the sulcus, a surgical PI which is pre-existing or a sector iridectomy which is pre-existing may always come useful. The length of the tube needed would be 1.5 mm for anterior chamber placement and about 1.5 to 2.5 mm for placement in the sulcus, depending upon the size of the physiologic pupil or the presence of a PI. A good bevel is mandatory for easy placement through the long scleral tract. And tube entry for anterior chamber placement would be about 1 to 1.5 millimeters away from the limbus, and for sulcus placement you will need to plan about 2 millimeter away from the limbus. And the scleral track is created using a 23 gauge needle. As you can see here, 4 millimeter away from the limbus, a point is marked and a scratch incision is created with a 15-degree blade. And a 23 gauge needle is used to create the scleral tract and anterior chamber entry. At this point, it is important to decide whether you are going into the anterior chamber or into the sulcus, and how much of the bevel needs to go into the scleral tract before your proposed point of entry. As you can see, if I am planning anterior chamber entry in this case, I need at least 80% of this bevel to be inside the scleral tract, after which I change the direction of the needle to be exactly parallel to iris and enter into the anterior chamber. So this is the entry into the anterior chamber. The bevel goes in about 80%. Now the globe is rotated towards the surgeon and the needle is made exactly parallel to the iris. And the anterior chamber is entered completely. The entire bevel needs to go in. Using a McPherson and a tying forceps, now the tube can be fed into the scleral tract. And since the chamber rarely collapses during the entire procedure, it is quite simple to put the tube into the scleral tract at this point. So just to stress the point on the direction of entry into that anterior chamber, as you can see, the direction of the scleral tunnel, that cannot be the direction of the anterior chamber entry, since you would be directly aiming towards the cornea. At this point, the direction has to change to be exactly parallel to the iris to attain a tube position as seen in this AIOCT image. So patch-free tube gives less dependence on eye bank procured tissue, and there are no concerns about transmission of pathogens. You get a smoother ocular surface with better cosmesis, but intact healthy tenons and conjunctival flap are mandatory for patch-free tubes, and the ideal site of tube entry would be 11 to 1 o'clock away from the lid margins. This is the Orolab Aqueous drainage implant with and without scleral patch graft in refractory and adult pediatric glaucomas. A comparative study. This is a retrospective study which showed that none of the eyes without the patch graft experienced a tube exposure over a period of 2 years. Similar results have been found in earlier studies. So it's important to ensure that's a well-formed anterior chamber at the end of surgery. There's a large variability in the opening, closing, and reopening pressures of the Hemet glaucoma valve. Very often you see that Hemet glaucoma valves, the chamber does not form as well as you expect at the end of the surgery. And when hypotony is anticipated, it is good to fill the anterior chamber with Helon or leave it half filled with Helon. And in spite of that, if the chamber continues to be shallow, and especially in eyes predisposed with hypotony, it may be a good idea to put a ligating suture if the anterior chamber persists to be shallow at the end of surgery. As you can see, there's a lot of ooze from the posterior aspect in this AGV, and I could form the chamber only after placing a single ligation suture with 6 ovicri. Post-operative management, anticipate tube opening at 6 weeks. Around 5 to 8 weeks would be the time when you would expect the non-valve device to open. Optimize and step down anti-glaucoma medications close to tube opening. Look for obliteration of the ridge. As seen in the image above, the ridge of the non-valve device is very markedly seen. It is a well-defined ridge before the opening of the tube. And as soon as the tube is open, you get this diffuse bleb over the ridge. And if the visualization is difficult, it is also a good idea to do ultrasound, serial ultrasounds, to look for the opening of the tube. Cycloplegics and topical steroids need to be continued 3 to 4 weeks after the opening of the tube. And the patient also needs to be counseled regarding when the tube is expected to open and how he can have a sudden change in vision around that point. To summarize, meticulous preoperative planning is the single most important part of the surgery. Pre-ligation of the tube will help save time on table. Intraluminal stenting of the RD is useful in eyes which are predisposed to hypotony. Gentle priming of the AGV is important. Mark the limbus before traction. Have a good exposure and a blood-free field. Every time confirm plate position. Have a good bevel. ideal tube position and length, and 23 gauge needle can be used to create a 4 mm long scleral track and enter parallel to iris, ensure a well-formed anterior chamber at the end of surgery, and proactive post-operative management. Thank you.
Thank you, Neetu. I think there is another award session here immediately after this. So any questions, we will take it at the end of all these presentations. We have 4 presentations. We'll take it at the end of the presentation. So for the next 15 minutes or so, I thought I will just discuss a few important practical aspects of how to route tubes into positions of adequate anterior chamber depth, some practical tips about sulcus placement of tubes, and also what to do if you're planning a repeat tube. So Neetu had already shown this, and this has become one of my most favorite slides. You have to be working around this 2.83 millimeter distance from the tip of the needle when you change the position into the... You're not hearing?
Volume is low.
I think I need to shout then. You are not hearing, Moiti?
It's low hearing, sir, but it's very low.
You should find ways, device ways to see that the tube is placed as close to the iris as possible. So this is a patient who had a lot of anterior pass. There was no way we could have placed the plate has been placed in the supratemporal quadrant, and that of course is the most preferred quadrant of choice for placement of an episcleral plate of any glaucoma drainage device. And it's only about much far away from the original position of the tube that we have adequate depth of the anterior chamber available for a safe placement of the tube. So this was already shown. So initially it is parallel to the sclera. You just advance it forward, and a particular predetermined place you change the plane of the needle entry to iris plane parallel. Initially it is parallel to the sclera, so you get into the anterior chamber at a safe distance away from the endothelium. So now the difficult part is how much of the tube do you trim to get an optimal length of the tube in the anterior chamber. So this is also very important. Once before you mark the tube, it's important that you push your episcleral plate back so that it is in its original position, where it has to be about 9 to 10 millimeter posterior to the limbus. So by trial and error, we found that if you mark the tube about the distance, if the distance from the scleral groove which you fashion, and that distance from the tube should be the distance of the tube that you trim, you get an adequate length of the tube in the anterior chamber. This was about 6 millimeters away from the tube. So we have trimmed the tube 6 millimeter by draping it over the cornea anterior to the limbus. We drape the tube and trim 6 millimeters, make a good anterior bevel, and you place it into the anterior chamber. You get an optimal length. This always used to be an issue because sometimes we trim it too long, too short. So if you trim it, and you can place an additional tube stabilizing suture there to make sure that the tube, the extended length of the tube lies flat on the sclera. And ensure that you have adequate tenons and conjunctival closure. So this is what I was mentioning. Drape the tube over the cornea and trim the tube to a length equal to the distance of the tube from the scleral groove fashioned for tube entry to optimize tube length in the anterior chamber. So this is about 3 months post-op, and this is late post-op, and these are especially useful. This is 4 years post-op, especially useful in accent field rigor, eyes syndromes, and other patients who have a lot of anterior pass. So ensure that you route tubes into positions of adequate anterior chamber depth. Coming to sulcus placement of tubes, It's quite easy if you have a lot of if you have anterior pass at the supratemporal quadrant where you're planning to insert your tube, especially in a post-PKPI, you see a lot of anterior pass. In many patients with neovascular glaucoma also, the iris is tented up. It's quite easy. Again, try to find out areas where you could take advantage of. This first patient had seems to have a sphincterectomy there. This patient had a peripheral iridectomy through which we can put in the tube into the anterior chamber. And also in uveitic glaucomas, there's a lot of posterior synechia. The tube is plastered onto the PCIOL. See this, this is another video where there is a lot of anterior pass, and we are planning to place the tube in the sulcus. So this is 2 millimeter medial to the original position of the tube. And you might have to make that transition a little earlier, but if there's a lot of tenting up of the iris, there's not much of difference between your insertion into the anterior chamber and also into the sulcus. I just put up this video just to show the practical difficulties we might experience on table. So because it's a very sharp needle, you are able to get it in between the iris and the PCIOL. But again, the iris is totally plastered there. Taking back the needles from the anterior chamber is also extremely, you need to be very, very careful. You need to ensure that the track closes it's on its own while the needle comes out. You should ensure that your second hand should not be applying too much of pressure on the globe where a lot of aqueous gush can happen. Again, another important tip, if you want the tube coming into the sulcus, going into the sulcus and coming out of the pupillary border, you need to measure the length of the limbus from the pupillary border. If you measure the length of the limbus to the pupillary border, and if you trim the tube at that particular position and then you route it 2 millimeter medial, you can ensure that you get an adequate length of the tube in the anterior chamber beyond the pupil. And this is something you will definitely experience. This tube doesn't go into the sulcus. Even if you have a good anterior bevel, there is this posterior synechia there onto and usually a cyclodialysis spatula usually will help. But this was an extreme case where there is so much of, I am trying to get into the anterior chamber. Because of this anterior pass, there's an inadvertent iridodialysis there, a small iridodialysis. Luckily, it didn't bleed. Trying it another side because all over there is pus. I'll just fast forward it a little bit. So much more anterior small paracentesis, and trying to get the tube into the beyond the pupillary border in the sulcus. So once you have the needle entry in the correct position in the sulcus, it still we may not be able to really get the tube into the anterior chamber. You just keep pushing the tube, it just tenses up the iris. Finally, we needed help from iris retractors to get this tube into the sulcus beyond the pupillary border. 2 iris retractors pulling the iris up, and then but this is an extremely rare case. Usually with this kind of movement, or with this manipulation of the cyclodialysis spatula, usually we are able to get it into the correct position. So that was the post-op. Luckily, the patient is doing well as of now, but with this much of anterior pass, you never know when the cornea is going to start decompensating. So another important tip here is drape the tube over the cornea and trim the tube to a length equal to the distance of the pupillary border from the limbus. That is the original position of the tube, and then route it 2 mm medial. You will get it in an ideal position in the. You could also plan to leave the tube bevel down behind the iris, provided you can visualize the tube tip in the dilated state in sulcus placement. Coming to a failed GDD, what are the things that you need to keep in mind when you need to plan for a repeat tube? So the most important thing is prefer the superior nasal quadrant as your second quadrant of choice for implantation of the second GDD. And the surgery is exactly the same as what Neetu showed. It's just a mental block. You just sit on the slightly towards the nasal side of the patient and think that you're working supratemporally. Everything is the same. The problem occurs when you have a failed tube supratemporally and you have multiple surgeries by the vitreoretinal surgeon, and you have these staphylomas in the supranasal quadrant, and you will have to plan for an infranasal tube. This becomes challenging, far more challenging than a supranasal implantation. I think I'll just, the plate implantation is the same as what Neetu showed. Actually, the infranasal and the supratemporal quadrants are completely devoid of these oblique muscle tendon complexes. So it's extremely easy, and patients also very, very rarely complain of diplopia if you're working on these two quadrants. It's the same. You identify the medial rectus and the inferior rectus, and you place the episcleral plate adjacent wings beneath adjacent rectus muscles. Only thing is, every time you handle tissue there, make sure you handle the tenons, and even if you give the tenons to your assistant, make sure that the assistant holds the tenons. It's very, very important. Also, for suturing these episcleral plates in the infranasal quadrant, sometimes it's useful to hook a particular muscle, give it to the assistant, she can hold on to it, she can even hold on to parsi, that is the assistant holding the tenons. And then you can slip it beneath the inferior rectus muscle. So now this is the difficult part. In most of the surgeries that we do, we are working away from us. And this is one area where we are planning to make your needle entry towards you. Again, 4 mm is little difficult. 4 mm scleral tracks are difficult in the infranasal quadrant. We prefer to have about 3 mm scleral track. Again, 2 mm medial to the original position. And then you make that groove that which Neetu already showed, partial thickness about 50%. And then, see, this is the length of the tube that usually my assistant gives me for a supra, but you will have to play around with the length of the tube and length of the needle and also the bend of the needle to ensure that you are, see, I have reduced the length of the tube, length of the needle, but again, the bend is not, the bend needs to be much more acute because there is this nasal bridge which is going to really compromise your hand movements there. Again, the mental calculation, where do you dip into the anterior? This is extremely, that's why each of the videos has this needle track entry. Extremely important to prejudge where you want to dip into the anterior chamber. So here, it's again almost the 2.8 because it's a 3 mm track. And see, at this 2.8 mm of the needle has entered the scleral track. You change the position into just like your keratome entry into the anterior chamber during cataract surgery to ensure that the needle gets into the anterior chamber as close to the iris as possible and away from the endothelium. This is the most challenging part of infranasal tube implantation in quadrants other than the superior quadrants. Again, bringing out the needle also has to be very slow, ensuring that the track self-seals on its own while it comes out. Another tip here, this again ensuring that the episcleral plate is positioned 10 mm posterior to the limbus and then marking it 2 mm. And another important tip is if you want to create an anterior bevel in an infranasal quadrant, you need to go underneath the tube. Always you will be trimming over the tube. This took us months and years to find out. We used to cut like this, get a round bevel, and then sit and pray, and the tube just doesn't go into the infranasal quadrant in the anterior chamber. We found out that if you go underneath the tube and make an bevel, you get a good anterior bevel for infranasal implantation. It is important to have skills to manage implantation of glaucoma drainage devices in quadrants other than the supratemporal quadrant to preserve useful vision in certain select situations. Again, a few points here. 4 mm scleral track is difficult. Adjust the needle length bent, which I already discussed. Scissors underneath the tube to fashion an anterior bevel. Patch material left to the comfort of the surgeon. Remember, you're working towards you in the infranasal quadrant. And to summarize, if you have a this is a retracted tube, failed GDD, you need to go to the supranasal quadrant. If supranasal quadrant is intact, the patient I was showing you had no place for a superior nasal implantation, and then we had to go to infranasal. And on a very rare occasion, this is a monocular Sturge-Weber boy who had expulsive hemorrhage in one of the eyes, preserving vision with the third tube infranasally. Thank you very much. We will have Dr. Kavita, who heads the glaucoma services at Aravind Hospital, Pondicherry, talk to us on managing post-operative hypotony and also the post-operative raised pressures after glaucoma drainage device implantation.
Thank you, sir, and thank you, AIOC, for the opportunity. So basically, I'll be covering the intraocular pressure-related complications following a glaucoma drainage implant. To start with, we'll deal with the hypotony in GDD. So there are many definitions followed in many studies. Statistically, it is defined as an intraocular pressure less than 6.5 millimeters of mercury. That is more than 3 standard deviations below the mean intraocular pressure. In TVT study, it was the persistent hypotony was defined as an intraocular pressure of 5 millimeters of mercury or less at 2 consecutive follow-up visits, whereas in ABC study, it was defined as intraocular pressure less than or equal to 5 millimeters of mercury. So the hypotony following a glaucoma drainage device, especially following a non-valve glaucoma drainage device like RD, can happen in 3 different phases. The first is the early post-operative hypotony. The early post-operative period, the causes can be as shown here. It can be a peritubular leakage, and our chief instructor, Dr. George, was repeatedly stressing the importance of making the needle track, and while we come out, he said that it should self-seal. That is very, very important. And when we take care of this peritubal leakage, completely from this post-operative complications, that can be easily an avoidable one. So we have to make sure we make a proper scleral track so that the tube will snugly fit inside the track. The next cause in the immediate post-operative period can be inadequate tube ligation during the surgery. Just to avoid the same, we always go for 2 ligation sutures so that by chance if one becomes loose, the other will always be there to take care of the hypotony. The other can be because of the venting slits. It is not mandatory to make venting slits in all the patients, and wherever it is avoidable, it is better to avoid that. And also there are some tips in making the venting slits. So we can see here, this is the tube entry side and the venting slits are being made here. It is always good to make the venting slits little bit posterior, more towards the ligation suture, so that in case of this hypotony related to that of the venting slits, you have a anterior portion of the tube available where you can apply a religation suture. So that we have to keep in mind. So the next phase where we can expect hypotony following a non-valve glaucoma drainage device is when the ligation gets absorbed. It happens around 5 to 6 weeks time, and most often when the hypotony happens, there will be a severe anterior chamber inflammation also. When the chamber is formed only with inflammation, usually it resolves around 72 hours. And we can see here, and once the ligation opens, the anterior edge of the foot plate, episcleral plate, will get obscured and we'll get a good diffuse bleb to visualize. And the most dreaded complication is the vision threatening one is the unexplained late hypertony, which can be accompanied by choroidal effusions, choroidal hemorrhage, and hypertony maculopathy. So how to manage? As I said, in the immediate post-operative period, when it is related to the ligation absorption, initially we can observe the patient and start the patient on topical oral steroids or cycloplegics, as we always manage with hypertony. And here we can see a patient, a thick fibrinous membrane, almost a flat anterior chamber because of the hypertony following the RD. When we have such patients which is not resolving with medical management, we usually either can go for a tube religation, ab interno stenting using a supramid suture, and tube religation with or without a CD drainage, depending upon the extent of the choroids. So usually when it is not resolving in 24 to 72 hours, it is like better to intervene. So here, so there's a small video demonstrating tube religation. We can see here how shallow is the anterior chamber, and there is a thick fibrinous membrane in the pupil. So after forming the chamber and giving subtenons, I am placing a traction suture, and careful dissection should be made the area of the tube. And one more tip here in this patient is, you can see here, this is one of my few initial cases where I was regularly using the patch graft, and nowadays when we are entering 4 millimeter away from the limbus, and we have good evidence from our chief instructor to show that patch grafts are not mandatory in all the patients. And we can see here, though I have used patch graft, I have limited it to cover the anterior most part of the tube, and the posterior part is not covered. So in these patients, it is very helpful, especially when such hypertony happens, just to make a small conjunctival nick and religate the tubes. So that also like one of the tips which I wanted to share. Here I am using a cyclospatula to separate the tube from the surrounding fibrous tissue, and then using the same vicryl suture to ligate in the same fashion as we routinely do during the surgeries while implanting in the primary surgery. After religating the tube, the conjunctiva is carefully closed, and then we have to form the anterior chamber. We can see how thick fibrinous membrane has formed because of the hypertony related inflammation. So now it has become very much easy with the availability of supramid suture. 30 supramid suture is available from Arolab. When the hypertony happens, like we have the option of stenting the tube, intraluminal stenting. I am making 2 side ports, one closer to the tube and one exactly away from the tube entry. Just creating a bevel as usually we create it for the tube, so that its entry into the tube becomes easy. So 5 to 6 mm of supramid suture, 30 supramid is being inserted into the tube. I am using a MVR forceps so that it can easily enter through the side port. And care should be taken to push the supramid suture completely into the lumen of the tube, so that it should not be protruding into the anterior chamber. So this is a patient who presented with the hypertony, whose surgery like we saw just now. It's like a preoperative picture. We can see massive choroidals here, and we can see a stenting over here, and the chamber formed very well, and the hypertony completely resolved in the next 2 to 3 weeks time, as it is evidence in this B scan pictures. So, and Dr. Neetu was also showing the importance of using ripcord, and Dr. Jat sir was just suggesting me to use the ripcord suture in almost all the patients. So we can place the ripcord suture and then ligate the tube before even inserting into the under the muscles and fixing the tube. And while ligating, we can make sure like to put 2 ligation sutures. One over the. Sorry, the video is not playing. So one suture can be placed over that supramid, and the other suture can be placed just anterior to the top of it, so that the issue of it not being fully like tight enough can be easily avoided. And we can just can close the. I'll go to the second slide. So this is it's moving on its own. Please stop, I can move. So we can see the supraumate suture under the conjunctiva. It can be left like this, and it can be removed by a small incision. That incision can be closed with a single vicryl suture. So this is a patient where I had used a supraumate suture, and even after 6 weeks the intraocular pressure was around 30 with 2 anti-glaucoma medications, and hence I decided to remove the suture. And once I removed the supraumate suture, we can see here a nice diffuse bleb, and the intraocular pressure came down to 12 millimeters of mercury. Even when we insert supraumate suture, it is better to delay the removal around at least for 6 weeks, and then assess the pressure once the ligation gives way, and then decide on removing the supraumate. So in that way, we can take care of hypertony. So this study, the Ahmed versus Barwell study, found that at the end of 5 years, the hypertony related complications were more in Barwell than that of the Ahmed group, and as we all know, it is more common in non-valve devices. So these are some of the pearls. Most of it I have shared then and there only. The one is tube should snugly fit into the scleral tunnel, and consider suturing the entry point. The scleral tunnel entry, whatever we are making, it's always good to suture that so as to avoid the peritubular leaks in the immediate post-operative period. Good to have 2 ligation sutures and venting slits only if needed, and it can be placed closer to that of the ligation so that you have good amount of the tube available anterior to that of the venting slits to religate whenever it is like needed. Patch graft, even if it is needed, please limit it to the anterior part of the tube, and so that the posterior part can be visualized and can be managed in case of hypertony. And planned ripcord sutures in prone cases is like very helpful. So moving on to the hypertensive phase, any intraocular pressure more than 21 millimeters of mercury during the first 3 months in the absence of tube obstruction is defined as a hypertensive phase. So usually we can see an elevated thick-walled cystic bleb, and before calling a patient as having a hypertensive phase, it is good to rule out certain causes of tube blockage or a valve malfunction or aqueous misdirection. Here we can see a thick debris. This is following AAGV in a patient with a traumatic glaucoma obstructing the tube. Here we can see thin fine strands of vitreous blocking the tube, and as we all know, whenever we are implanting a glaucoma drainage device, fibrous capsule forms over the end plate, and aqueous humor usually pools in the potential space between the end plate and the surrounding capsule, and the flow occurs through the process of passive diffusion. That is what gets absorbed by the capillaries. But the thickness of the capsule will determine how the hypertensive phase is going to be, and there is even evidence to say that increased hydrostatic pressure in that potential space between the device and the capsule can make the capsule very stiff because of the aqueous collection over there, and that is more common with valved devices. So it depends upon the resistance to the flow through that of the capsule. As we all know, in valve devices, the flow starts immediately after implantation, and hence in the immediate post-operative period, aqueous is supposed to have a lot of pro-inflammatory factors which can cause thickening of the capsule and higher chances of this hypertensive phase. Whereas in non-valve devices, as we all know, we ligate, and for first 6 weeks it's not going to function till the fibrous capsule forms. By then the inflammation, post-operative inflammation comes down, and hence there is lesser incidence of hypertensive phase with we can obtain a very lower intraocular pressure as compared to that of the valve devices. As we saw, it is more common in valve devices, and various studies have reported various percentage of this hypertensive phase. And there are certain factors which can determine this hypertensive phase, including higher preoperative IOP, presence of myopia, previous glaucoma surgeries, and also the material of the end plate. So evidence has shown these factors. And during the early post-operative period, initially we can use aqueous suppressants to manage the hypertensive phase, and when it is not helping, probably we have to go for other interventions. Using the aqueous suppressants can reduce the intraocular pressure, improve the success rate, and also can reduce the frequency of hypertensive phase. So when this is not helping, surgical management will be bleb needling, bleb wall excision. Sometimes we can even need to do a valve dissection or ligating the tube. And when nothing is helping, as shown by our chief instructor, some patients might need a second tube or a diode cyclophotocoagulation. Thanks to Dr. George sir for providing me this video. This is a child with Following an RD implantation, a child in aphakic glaucoma, we can see a thin cystic capsule over there. A careful dissection is, conjunctival dissection is made over the encapsulated bleb, and the conjunctiva is separated from the subconjunctival tissue. So L-shaped conjunctival incision is being made, and so that the post-operative apposition will also be good at the end of the surgery. The careful dissection is made, separating the conjunctiva from the fibrous capsule. We can see how thick walled is this capsule. And as we give the nick, we can see a lot of aqueous is seeping out through the capsule. And this initial incision can be deepened. And we can visualize even the foot plate over there. And the fibrous capsule is over the foot plate is like being removed. And at the conclusion, it is since we are removing the capsule, fibrous tissue around the end plate, it is good to put a religation or ligating suture so that it will not result in hypertony and the conjunctiva is opposed in a usual manner. So this particular study in the Indian population I have basically done to compare RD and AGV. They found that if AGV patients are started on anti-glaucoma medications, especially aqueous suppressants, whenever the intraocular pressure was more than 12, was very helpful in blunting the hypertensive phase. And this particular study reported that preoperative IOP and one previous glaucoma surgery as risk factors for developing hypertensive phase. And this is from our chief instructor, Dr. Josh. And following an RD implantation in the series, they found a hypertensive phase was seen in 32%, which was around 2 to 3 months after the surgery. And the good thing is most of the patients, in almost 94% of the patients, it just resolved with additional anti-glaucoma medications. And the success rate between the group which developed the hypertensive phase and the group which did not develop the hypertensive phase was not statistically different. And in this particular study, like Pakravan et al., they divided the patients following an Ahmed glaucoma valve implantation into two groups. One group was started on aqueous suppressants, initial aqueous suppressants, and the second group received conventional stepwise treatment whenever the intraocular pressure was high. And they found that at the end of 1 year, there was a significantly higher success rate and reduced hypertensive phase in patients who received initial aqueous suppressants. And hence, aqueous suppressants like beta blockers and carbonic anhydrase inhibitors can be considered in the early postoperative period, especially with AGV. And it reduces the levels of aqueous humor inflammatory mediators, and the aqueous with pro-inflammatory factors reaching the space around the episcleral plate will also become less, and hence lesser chances of fibrous tissue on hypertensive phase. Thank you.
Thank you very much, Kavita. Kavita has to leave for another session where she has to judge free papers. If there are any questions on managing hypotony or hypertensive phase following glaucoma drainage device implantation, we will ask Kavita to take it before she leaves.
That's what, like,
does it make sense to make?
So it is always good to be on the safer side. If you are like too much confident with like one ligating sutures, it is not mandatory. But I feel more comfortable that in case if I trim closer to the top of the knot, or in case by chance one is getting like absorbed early or something is happening, the other is always there to take care. But I think with the supramed suture, when we do ripcord for all the cases, probably even one ligation suture will do. So because we have always the ripcord to take care of the hypertony.
Devendra, I'll just add on to what Kavita said. You cannot be sure that it will dissolve the same day. It can. That is one thing. Second thing is, I would strongly advise everybody to use intraoperative stenting with Supramid. It's called Supralon now. Supramid is a competitive brand. Supralon is available. Orolab has commercialized it. It has to be used for every non-valve device. And you have one ligature suture over the Supramid. You have one ligature suture over the supramid, one ligature suture just a little anterior to the supramid, because in a rare instance of the supramid getting exposed and we are not able to, through the conjunctiva, and we are not able to ligate it. So it's a very rare occurrence, but it's occurred once, and we found that the second ligature which holds the tube anterior to the supramid has prevented the hypotony, and that dissolves at 6 weeks. And I'm sure Devendra is also using 2 ligature sutures. So, your question.
Yeah. So just a comment, for a chronic hypotony following trap or even for this stenting, sometimes there is a iatrogenic cause for hypotony also, like use of carbonic anhydrase or beta blockers. So along with standard treatment of hypotony, you have to stop these drugs. So we have seen some cases with this also. And for tube with Saniki, I think you can create a large PI to place the tube in the sulcus, so that is visible rather than to place it too anteriorly so that it is visible. That is very long length of the tube. Thank you.
So most of these
How long would you wait to intervene if there is hypotony, AC shallowing, but there is no touch, no iris corneal touch? How long would you wait to intervene, or when would you reform the AC at any point? Pressures are, let's say, 4 to 6 with a non-valve device.
So with the non-valve devices, as like I was shown in the slides, usually we just wait for like maybe 2 or 3 days, and usually in the managing hypotony following a non-valve device is like little different from that of the no trabeculectomy, where you can just wait and the fibrous tissue will form, and then it will be taken care of. That slowly the chamber will form. So in my little experience, whatever I have faced is, even when the ligation suture gives way, when you are getting hypotony, in most of the patients, like the chamber, if it is formed with severe inflammation, definitely they will subside. But when the chamber is like so flat, in my experience, I have not seen it getting formed with the conservative management, and 100% of them, in my experience, they landed up in having either intraluminal stenting or religation.
Again, to add on to what Kavita said, this can be prevented by intraoperative supramid stenting, because you can wait. You can wait till up to 8 weeks before you can pull out, and by then the fibrous capsule is well formed. Initially, we had this fear. Patient comes at 6 weeks post-op. Patient comes, sometimes this Dr. Professor Keith Barton from Moorfields has a good animation where the ligature gives way, the whole globe collapses. That can be prevented by this supramid stenting, and we have many children post-operative 1 year, supramid nicely lying underneath the conjunctiva, pressures well maintained. And one only problem is this problem with non-valve devices now is a very late unexplained chronic hypotony, where this ab interno supralawn stenting has also become a blessing nowadays. That is the advantage, I think. This is a multi-filament. It's a pseudo monofilament nylon, Devendra. I haven't seen a granuloma being formed. No, but what do you do after that? What did you do after that?
The subconjunctival space where we are leaving the supramid post-operative period, probably.
Thank you, Kavita. Thank you very much.
Thank you, sir. Thank you.
So this is the last of our presentations for the day. Managing tube blockage, tube cornea touch, tube retraction, and tube plate exposures. So this is not very rare. Tube blockages with blood or fibrin in the early post-operative period, and all of them resolve very well. You don't have to do anything for a blood clot which is occluding the tube, or a fibrin that is occluding the tube. The problem comes when the tubes get occluded with iris, vitreous, or silicone oil. So here the offending material will have to be removed from the tube lumen to ensure you're restoring the flow through the tube to the aqueous reservoir around the episcleral plate. Unfortunately, this patient had a surgical PI right at the site of the tube, and the iris went in and blocked the tube, causing high pressures. And the tube was also being trimmed to ensure that this doesn't recur. So to trim tubes, you can either insert a Sinski inside the tube and then trim off the tube, or you can hold the tube which is much more convenient. You can use a microrhexis forceps to hold the tube and trim the tube. That was the post-op. Tube blockages with vitreous is a major issue. Sometimes even a yak capsulotomy can, later on we have seen vitreous coming and blocking the tube. I nowadays I don't do an anterior vitrectomy for tubes blocking. I leave it to my vitreoretinal surgeon. They so easily take out the complete clearance of the vitreous occurs from the tube. And this is also an important thing when you're planning for pars plana tube insertion. You should have access to an excellent vitreoretinal surgeon who will shave off the entire vitreous base. Otherwise, surprises like this is not infrequent. Anywhere some vitreous remaining, your tube in the pars plana and the vitreous cavity will get onto the tube and block the tube lumen. Silicone oil, another problem. You might think only a superior tube gets occluded. Even inferior tubes can get occluded with silicone. And the teaching now is to put in your tube in a silicone oil in an post-SORI. You can put in the tube in the supratemporal quadrant, but leave the tube a little long in the AC close to the iris. They say the tube escapes the tube lumen. It is seen around the tube rather than occluding the. If you see very carefully, this is very useful. Putting a slit at the tube, you can see the slit on the tube lumen is absolutely clear. But you have silicone oil all around. So this is another patient, a neovascular glaucoma. Tube was in the sulcus, tube retracted, came with very high pressures. One of our friends in the audience was suggesting, we were thinking initially of repositioning this tube into the anterior chamber, but we thought it would be better to just do an iridectomy over the tube. So this was very high pressures, tube completely occluded by the iris. So these 2.2 bevel-up keratomes are extremely useful to do resurgeries rather than your paracentesis knives. These actually seal much better. So inserting, filling up the anterior chamber with viscoelastic, and you should know where your tube lies in the anterior chamber. You can actually feel it with a second instrument. See, that is where the tube is. And this becomes much more easier than having to identify the tube and dissect out the conjunctiva and reposition it. So an iridectomy exactly, probably a sphincterectomy, exactly over the tube. Tube is nicely seen now in the sulcus. And also see this healing. I just put up this picture here because even without patches, this conjunctival healing is very good through this 23 gauge scleral tracts. Coming to the second part, tube positioning in the anterior chamber is absolutely critical. This is probably the most vital part. See, on a cursory glance in the postoperative period, this would look normal, but I am worried because if you put a slit on the cornea, on the tube and on the iris, see the distance. This slit on the tube is very close to the cornea and it's quite far away from the iris, and no wonder after over a period of time it started, the cornea started decompensating. You just cannot afford to leave tubes close to the endothelium. Again, see the slit. There is absolutely no distance between the slit on the tube and the slit on the cornea. And again, focal corneal decompensation. You should make a slit and assess this right from entry into AC. Tubes have to enter the anterior chamber below the Sholby's line. See, actually you have it's an opaque area. You have no way to find out where you're going to enter the AC in the at the limbus. But ensure that right from the entry into the anterior chamber, you have an adequate distance, which will make sure that your cornea remains clear for a prolonged period of time. You have to find ways, and as I was saying, again, my favorite slide, you have to find ways to make it work in your hands. Work what? Work that the tube is far away from the endothelium. Cornea-related complications are also a big headache. You need to reposition these tubes. You cannot afford to trim these tubes if the tube entry is close to the endothelium right from its entry site. Suppose the entry site, it's quite close to the iris, and as one of the slides which Neetu showed, after that the tube is tenting up towards the endothelium, you can afford to trim these tubes. This is one of those patients. Again, this is a video where, especially in children, you cannot just afford to leave the tubes close to the cornea. So this is the needle track, which has been shown multiple times, but I am again, see the limbus is totally stretched here in children. So I try to, see, that is where I'm changed the plane of the needle, I'm getting into the anterior chamber. Everything looks fine. It looks as if I have gone into the anterior chamber at a safe distance away from the endothelium. But on trying to insert the tube, I find that it is much more closer to the endothelium than desirable, much more closer to the cornea than desirable. See, these are useful devices to maintain vision in refractory glaucoma, but these are also dangerous devices unless used meticulously. Right at the entry, I know for sure that this is much more closer to the endothelium than desired, and you just cannot afford to leave them intraoperatively like this. You cannot think that, okay, I have left it, it's okay, and things will be better post-operatively. If you don't see a tube in the anterior chamber intraoperatively while closing, you are not going to see it post-operatively the next day. So this is the advantage of these 4 mm self-sealing scleral tracks. You can always make another one, and you can always dip a little earlier than what you had dipped initially. See, I'm dipping a little earlier, and I can see that it's difficult to show because it's not a three-dimensional picture, but still I can see that the needle is going a little more posterior than my initial track. And these are self-sealing tracks. If you see, most of these, there is absolutely no manipulation in the anterior chamber, no viscoelastic inserted into the anterior chamber. I would also suggest that you trim the tubes after you make we used to trim the tubes before making the scleral track, but it will be better to trim the tubes after you make the scleral track, because suppose you want to make a different track a little away, you still have adequate length. You can make a slightly longer tube, trim the tube so now this is much more posterior than what was initially shown, the initial track. Coming to this is a video on tube retractions, and probably this will cover most of the practical aspects of tube repositioning, which becomes an important part of any resurgery with tubes, whether it's a tube corneal touch, whether it's a tube retraction, a tube exposure. You must know the practical aspects of how to reposition tubes. This tube was just about 1 month post-op. The tube had retracted. Again, try to preserve as much of tenons as possible, and ensure that while dissecting out the tenons, ensure that you don't damage the tube. So in that plane, if you make sure that you have created a plane just above the tube, And this is another advantage that we have noticed of not using patch graft. Suppose we use patch graft, it becomes even more difficult to reach the tube. And unfortunately, even the track is a little superficial. And this is the important part, getting to the bare tube. We feel, okay, now we have seen the tube, it will be easy to just pull it out. But surprisingly, even at 1 month, there is a lot of tissue that grows around the tube. So this is all the normal tenons dissection, but we have still not seen the bare sclera here. It will involve a lot of fine dissection to ensure that you expose the bare sclera. See, that is the covering, the fibrous covering that is formed around the tube, even at 1 month postoperatively. And we have to make sure that we dissect it out carefully from the tube and expose the tube. See, that is where you see some kind of bare tube you are able to visualize. Still, it will be better to just, unless we dissect out this fibrous capsule out of the tube and expose the bare sclera, you just will not be able to take out this tube. See, that is a fine tissue that needs to be dissected. After that cut, probably you will see the tube much better. See this part. This is where the tube bare tube has been exposed. And now you know for sure that you can pull out the tube. And to be on the safer side, always doing resurgery in non-valved implants, it will be better to ligate the tube before you take out the tube. Your 6-0 ligature sutures, just to be sure that you have not, this is just added precaution to ensure that just in case you have damaged the capsule around the episcleral plate, this will prevent hypotony in the immediate postoperative period. So the second track is fashioned. This is the left eye. It was placed 2 mm medial. So now you can afford to have another track almost along the position of the initial tube, and make the second entry with the tube in place. With the tube in place in the anterior chamber, this again ensures that the eye is firm for the tube track, to make the tube track. Again, your 23 gauge needle track, and then at a particular prejudged position, you are entering the anterior chamber. Again, coming out slowly, ensuring that the anterior chamber is as formed as possible. So a little bit of viscoelastic is being placed in the anterior chamber. And it's also important to pre-place the suture. Sometimes when you take out these tubes, you don't know where to suture the initial wound. So it is better that you pre-place the suture there before you pull out the tube, so that after you pull out the tube, you can just suture it off immediately. An X suture there. These are some of the very basic principles of tube repositioning. Because we have had difficulty finding the initial incision to suture, and having to place a patch graft in one of the patients whom we were not able to really clearly identify where to suture. Now the tube is being threaded into the anterior chamber through your new scleral tract, which is, see how much of tube is, so use of tube extenders or tube extending devices, it has almost been taken out of the equation in our practice, because you have this additional 2 millimeter tube which you can use to reposition at a later date. Luckily, this patient is doing well. See, totally retracted tube without a tube extender. You have adequate length of the tube in the AC. So carefully expose the bare tube. Prefer to ligate the tube. Fashion the new tract with the first tube in the anterior chamber and pre-place the suture before removing the tube. Tube exposures are also a big headache, nightmare for the glaucoma surgeon. Thankfully, with this present episcleral tunneling technique, this has come down, and most of these tube exposures occur 4 millimeter from the limbus. Most of these tubes, so if you can bury the tube in the patient's own sclera, the healing is much better, and our rates of exposures are really less. See, the much lesser ocular elevation, much lesser inflammation, much better wound healing. And the teaching is, once a plate exposes, you just cannot salvage the implant because of poor tissue integrity. But this is the only plate I have salvaged in my career. It was a very clean wound near the episcleral plate, which did well with continuous conjunctival suturing. And to conclude, I also want to say that not all battles are won. This was a tube which was repositioned into the anterior chamber, then repositioned into the posterior chamber due to multiple tube exposures, and then finally repositioned into the vitreous cavity. So once you have an exposure like this, there is no way we can repair this. You just have to pull it out, trim it, see whether you can place another tube in a different quadrant if the pressures go up later, or opt for a cyclodestructive procedure. Thank you very much. We'll be happy to take any questions regarding the basic surgical technique, also about complications, and also tubes in complex situations.
So when you take the ligating suture with Vicryl, you take only one throw or two throws?
So we take 2 throws and then make it watertight. 2 throws watertight, and then check for the complete watertight closure. You can have a small air column. You can see it going and then coming back, or you can even observe at the tip of the tube where the cannula is there, small bubbles might form. So it is 2 throws, complete closure, then 2 more single throws.
Oh.
You understood? 2 throws,
Yes.
complete watertight closure, then 2 more throws. For the over the supramid, I prefer to have another 1 more throw, because then there's a lot of manipulation. Invariably, 1 throw comes a little loose after insertion.
And for the intravitreal implantation, there again you have 2 more sutures before once the in the tube which is on the sclera.
Yeah.
If you have the intravitreal,
It's exactly the same. I didn't have to, even though sulcus pars plana tube insertion was also part of the course. I don't think we had time to do that, but then it's exactly the same. Only thing is the length of the tube in the vitreous cavity. It's about 3.5 millimeter. You drape the tube over the cornea. We are trimming 2 millimeter. You trim 3.5 millimeter and then insert it into the vitreous cavity, so that you can visualize the tube in the mid vitreous cavity on dilatation.
When you remove the supramid suture?
I didn't get you.
When you remove the supramid suture?
Yeah. So the supramid suture is, in our practice, the supramid suture is removed only if the pressures are high, and never before 6 weeks. It's never before 6 weeks. And I would personally advise, even if it is 7-8 weeks post-operative, till 7 weeks post-operative, if there's high pressure, you just get tied over it with all sorts of aqueous suppression and oral carbonic anhydrase. The whole surgery becomes much more safer if you can delay the supramid suture removal. And if pressures are normal and it's nicely lying subconjunctival, leave it there.
Okay, is there any alternative of supramid suture, like same thickness or same any alternative?
No,
like
but
where
now,
the supramid is not available.
yeah, now that's what I think I had told that with a lot of difficulty now Orolab is commercialized. It will be freely available. So other alternatives are you can use a 3-0 monofilament proline or nylon. But then the flexible, once you start using the supramid, the feel is much better.
Okay.
And even the healing, the removing the suture, and for the ab interno stenting, we have tried ab interno when we didn't have the supramid. We have tried ab interno stenting with 3-0 nylon.
Yes.
After 1 month, we saw the whole nylon lying in the anterior chamber.
Yes. And if you will not place the the patch or anything, if you tube implant underneath the conjunctiva only, in that cases, what is the distance of tube insertion from the limbus?
4 millimeters.
4 millimeters.
4 millimeters, and ensure that there is adequate tenons available for closure.
Okay, thank you.
This tube retraction is due to subconjunctival fibrosis?
We don't know, ma'am. We are not sure about it, why they should occur. Probably because of the way the tube is lying. I'm not sure why they should occur, and usually seen with children. Neetu, anything to add on to that?
No.
We don't know why they should occur. We have seen the tube retraction I showed. A very senior surgeon told me that adequate 2 millimeter length of the tube was there in the anterior chamber while he closed the. But I am not sure why anybody can. I'm not sure why it should occur. Probably, maybe or probably slight posterior movement of the episcleral plate is another possibility. Neetu?
Madam, where we have had multiple plate exposures in eyes which are resurgeries, like earlier retinal surgery, and we've had to dissect the conjunctiva a lot. And I also tried to not close the conjunctiva too tight. Like I tried to have a free, like the conjunctiva should be easily pulled at the limbus when you're finally suturing it. If not, I try to put relaxing cuts and pull the conjunctiva anterior. We have had plate exposures, very like 1 or 2, which are usually post retinal surgery eyes or multiple surgeries where we've had difficulty in the conjunctival dissection as such.
I think quadrant of placement and conjunctival health is the most important factors for plate exposures. Luckily, we don't see much of plate exposures.
Yes.
Yeah, it's impossible to.
We had to explant.
It's very difficult. You have to find ways on your own to ensure that. And what we really, I showed you that photograph where that 2.8 to 3 millimeter, that is really making a difference, because even if you cannot visualize the anterior chamber well, there's a lot of corneal edema, you cannot visualize the anterior chamber well, you still can make that judgment. So the 2.8, 3 millimeter of the needle has entered the limbus, then don't hesitate, don't go any further, just dip into the anterior chamber, you are going to see the needle in the anterior chamber.
To add a point there, madam, even if you find a landmark there, once the tip is inside the scleral tract, you won't really know where the tip is. So looking for a landmark doesn't really help once the tip is inside the scleral tract. Looking at how much the bevel needs to go in is the best possible clue at that point.
And lot of accurate measurements have made tube surgery much more safer. Especially just marking the tube before trimming the tube, we can ensure that you have an adequate length of the tube in the anterior chamber.
Your experience of bleb needling in non-valve?
In non-valved, Devendra, this.
Like you use bleb needling in 80-week cases.
But Devendra, we don't see much of problems of hypertensive phase in non-valve devices.
We see some cases because we have the IID, we don't know why it's happened. Because the hypertensive phase after 6 to 8 weeks not working. We don't know why it is not working. Have you tried bleb needling?
I have never tried a bleb needling over a non-valve device, and our results, we have published also the same. None of them had to, because we see so much of thick capsules over the AGV. These are much more thinner, much more diffuse. I'm a little surprised. Neetu?
Non-valve devices, we have also not done many, Devendra. We've had hypertensive phases, but covered by anti-glaucoma medications, maximum over few weeks, and then we could taper medications.
Devendra, 1 minute. That which the video that Kavita showed, I was just mentioning
It's
to
the
Neetu.
only-
Unfortunately, that was the only capsule excision I've done in an RD over the past 7-8 years. You can imagine the only, and unfortunately, I had that video to hand it over to Kavita. There have been so many we would have excised over the AGV, the capsules, a part of the capsule over the AGV.
I just tried in one case. I want to know your experience. If I come to the second wall, so I thought right on second wall, just dissect it with the lead metal that we used to do for AGV, and somehow it worked. So I want to know your core experience.
No. And literature also, there are studies coming up saying that post-operative mitomycin injections are helping in intraoperative, and post-operative mitomycin injections are helping in reducing the hypertensive phase in valve implants.
I'm using in AGV and really using like first week and first 1 month, and really raise a
What is the concentration you use?
point same for like that cases.
I'm suggesting that you give us a call and see every AGV.
Over the plate, yes.
You inject at what time?
1 week and 1 month. So what is the percentage? 0.1.
Help me to reduce the fibrous
I
capsule.
don't try to get us. I can't come and very in my cases.
Look at very often those rays coming when
Yeah.
over the plate.
In some cases, I went like for 1 month. You put the injection, it will be 2 to 3 weeks. I think Dr. Ganesh had more experience than me. He will listen 6 to 8.
The concentration is higher. It's
I
0.4.
don't think we are using such cases. They are all refractory cases. I don't think I don't spell it. I know my theory of this data is I don't have this thing of the guaranteeing us.
Needling of these
That I totally agree with that. Initially, we used to aspirate fluid from the T nodes. Then we used to start needling and finally excise a part of the.
during excision I've applied MNC medicine, interesting injecting MNC.
There is published literature on the same. I think if there are no more, yeah, yes, Techi. Niti, mic. I am worried when our own fellows have doubts.
Hello. Sir, does Dymox works for this thing, bleb encapsulation in case of AGV, sir?
How long can we give Dymox, Techi, for bleb encapsulation? See, you can try suppressing Aqueous in the immediate postoperative period if the pressures are high. So inflamed Aqueous with inflammatory mediators don't reach the fibrous capsule and don't, but I don't know whether Dymox per se can reduce bleb encapsulation. Probably in the early postoperative period, in a valve device, immediate post-op, and in a non-valve device, when the tube ligature dissolves and the tube patency is re-established, a lot of aqueous suppression may help with reducing hypertensive phase. But I'm not sure whether long-term Dymox will help to reduce hypertensive phase.
Okay, sir. And regarding like that pediatric tube cases retractions, sir, I have a doubt. Like, sir, is it because of the like more saccadic eye movement in the pediatric group? First things, and second thing is it because of the tissue elasticity is more in that cases, sir? Is that the
Highly
reason,
possible,
sir?
because the one way to make sure that tubes don't retract is to have these tubes as a snug fit in these scleral tracts. But as you said, that elasticity with pediatric age group, it's much more elastic, and we have often seen that even tubes placed well in the anterior chamber finally end up with a position more closer to the endothelium later. All this may be due to the more of less scleral rigidity in children. I didn't understand the first part of your point. I understood the second part. What did you say the first
Sir,
one?
I said like, is it like eye movements, saccadic eye movements more in pediatric case is also a reason, sir?
I'm not sure, but they say that micro movements of the tube can lead to some kind of is a predisposing factor for tube exposures, but I'm not sure about tube retractions.
Okay. Thank you, sir.
I think we will have to hand over the hall for the next session. Thank you very much for attending this instruction course. Thank you.